Good evening, everybody, and welcome to this edition of Orthopedic Specialist webinar. My name is Raghbir Khakha, and I'm going to be your host for this evening. It gives me great pleasure to introduce Dr. Stefano Palmisani, who's a consultant in pain medicine, and he's part of the team at Orthopedic Specialists. He's going to be talking to you today about suffering with chronic pain and your options for treatment. Stefano is an expert in chronic pain and neuromodulation, and he specializes in interventional pain medicine. He's actually a colleague of mine at Guy's and St Thomas's, as well as Orthopedic Specialists, where he's part of the pain team there. And this has got an international reputation for pain management. His particular focus is on minimally invasive endoscopic spine intervention, and he's heavily published with an interest in research and innovation. He's got a multidisciplinary team approach to pain management. And I know that a lot of the people who've signed up today will be patients, will be allied healthcare professionals, and those of you who like to work in a very similar fashion. As I mentioned, he's involved with publications, and he lectures and teaches worldwide. So we're very lucky to have him as part of the team. The wider team is multiple people ranging from hip, knee, shoulder specialists, spine surgeons, maxillofacial surgeons. So we have the whole plethora of orthopedic, maxillofacial and pain specialists in Stefano. So we're quite a wide team to cater all musculoskeletal problems. We do most of our work out of the Harley Street Specialist Hospital, which is where we do our consulting. We've currently got one day case theatre with the view to having a second one going online next year. So we do, there's some nice clinic rooms just on Queen Anne Street off Harley Street. We do our major procedures at the London Clinic, where we are very lucky to be part of the team there. And they provide us with fantastic facilities for our bigger procedures. And Stefano also does some of his procedures out of there also. So tonight's webinar, the topics are going to be, as the title suggests, about chronic pain. Why does it not go away? And options for treatment, specifically looking at spinal cord stimulation. So what it is, how it's performed, how does it work, who it's suitable for, and how well does it work? As part of all of our orthopedic specialist webinars, we offer 2 CPD points following the webinar. So you'll be sent a questionnaire, and once you've returned the questionnaire, you'll be given 2 CPD points. If you'd like to keep in touch with us and follow us on social media, Stefano has his own LinkedIn page, as do I, as does Orthopedic Specialists, and here are our Twitter handles. Most importantly, if you'd like to see Stefano or get any advice, get any input, or seek treatment, you can contact us via the Orthopedic Specialist email and phone number, which is detailed here, and also on our website, which is www.os.clinic. So feel free to capture the screen, and we'll be able to help you out. During this talk, I'm sure you'll have lots of questions, so please do not hesitate to put them in the question and answers or in the chat. We're very flexible, whichever suits you. And I'll put these questions to Stefano as we go through the talk. Hopefully, I'm sure it'll be a very informative evening, and we look forward to taking your questions. So I'm going to stop sharing my screen. I'm going to hand over to Stefano. Stefano, it's over to you.
Okay. Good afternoon, everyone, and thank you very much, Raghbir, for this very kind and nice introduction. So let me see if I can start sharing my screen. Okay, can you see it okay?
Yes.
Perfect, good. So as Raghbir was saying, I'm one of the consultants working at Guy's St Thomas's in the pain medicine department. And the idea of today's talk is to give you a very broad overview on chronic pain, minimal invasive treatment that can be offered for people with chronic pain, and with a specific focus on neuromodulation, which could be also called spinal cord stimulation. Now, generally, I mean, it's difficult to cover in 30, 40 minutes the topic of my old specialty, but I'll try to give you some hints, and I'm very happy to take questions at the end. So I'll try to summarize the flow of this talk with a series of questions, right? So that usually helps people understanding and following the presentation a bit better. So the first question is, how common is chronic pain? Because in the general knowledge, chronic pain is something that is not very common. But if you look at what has been published, especially in UK, it is extremely common. I mean, 35% of the population do have pain that persists for more than 6 months. And 10% of those have severe pain that is severe enough to cause significant disability and impact their quality of life. And on top of this, it is an age-related disease. It is low when you are young, but the older you get, the more likely is that you're going to develop a chronic pain syndrome. And if you look at the study that's been run in the GP practitioner surgeries in England and Scotland, looking for a specific subsection of chronic pain, which is the nerve type chronic pain, there is a prevalence of between 8 and 9% of the whole population suffering from severe chronic nerve type pain. So which kind of pain are we talking about? So this is a very big study that is called National Pain Audit that has been run in all or most of the pain clinic in UK from 2010 and 2012, and shows that the majority of the chronic pain that is seen in this clinic is spinal pain. We're talking about back pain, we're talking about neck pain, we're talking about back with some kind of sciatica type pain, so pain that runs down the leg. So the majority of those symptoms are coming from the spine. Now, to understand a bit better how can we treat chronic pain, we need to understand a bit better how generally pain works. So in our body, we do have pain receptors everywhere, and their job is to signal that there is something going on to our brain. So pain, most of the cases, starts in the periphery, in the foot, in the knee, in any tissue where there is something that is wrong. That most of the times is an injury, an inflammation, an infection. However, this kind of signal gets then transmitted through the nerves and through the spinal cord. In the spinal cord, there are some very sophisticated mechanisms. They're able to turn this kind of electrical pain signal up or down. In most of the cases, they turn it down. So the spinal cord acts like an amplifier in some cases, or a filter in other cases, to avoid that wrong signals go and reach the brain, and to facilitate that good signal that need to reach the brain take priorities compared to the rest of the signal. Once the signal reaches the brain, this is where we feel the pain. The signal can get transduced, gets changed, and finally our brain is able to understand that there is something going on, and that is not right. Now, these three key stations that I just showed you are the ones that are important in understanding how pain could be generated by different mechanisms. So you can see in green what I've written there. Acute pain is when the system works normally and it does its job, and its job is to collect some information from an injured site, amplify the information in the spine, and send it to the brain so the brain can actually act and do something. However, each one of these key steps might fail or might get damaged, and the system start working in a dysfunctional way. So you start to either amplifying signals that shouldn't be amplified. You start to hear signals in your brain that do not actually exist, or you start to have signal from the periphery where that normally are not painful, or they are just mildly painful. They are exacerbated because they've been there for a long time. Now, each one of these steps can be treated and in some way diagnosed by different specialists. Now you can see on the top right, if you have a mechanical problem in one of your joints, for example, you need the mechanics, right? You need someone that can fix the mechanical problem so the signal stops to be generated. At the very bottom, if you have an interpretation problem, so if your brain hears pain signals that do not exist, then you probably need a brain specialist to diagnose the problem. It could be either a psychiatrist or a neurologist. The pain specialist is a kind of a middle figure that usually is used to help understanding a diagnosis of pain, because we are exposed to patients that have all these three types of pain, and can also treat, especially the abnormal pain signal processing part of the pain. So this is where we play a significant role. And if you look at what happens in the pain clinics, that the same audit that I was mentioning to you before, you see that the majority of the patients that we see, they have both the mechanical peripheral pain or the abnormal filtering pain, right, if you wish. We can put some names, right? So the mechanical pain usually is either osteoarthritis with degeneration of the joints in any part of the body, or could be a torn ligament or a torn muscle. The abnormal filtering pain are usually pain that are caused by nerve damage or some neuropathy, like the one that is associated with diabetes or with chemotherapy, or the one that happens after surgery when by mistake the surgery has caused some damage to the nerves. And then there are these, the most common one are where like low back pain or fibromyalgia, where those mechanisms are all intricated one with each other. And it's our job to understand which one is prevalent, because the treatment is extremely different. So when we talk about treatment, the first thing that people would question is, okay, there are different mechanisms of pain, but pain is pain. So why cannot I take a painkiller? Why I cannot take morphine to reduce my pain level and improve my quality of life? Well, so there are many reasons why morphine and painkillers in general are not a solution. So the first reason is because they're extremely dangerous. You can see this is a graph coming from US, in UK, and in Europe. This is a bit less exacerbated, but the trend is similar. This is the number of deaths per 100,000 population due to painkillers. That could be prescribed painkillers like morphine, or illicit painkiller like heroin. This shows you that there is a huge increase in overdose deaths, and that is mirrored by the huge increase of opioids in US that has been, especially in the last 10 years, that has been used to try to treat chronic pain. So first of all, painkillers, especially opioids, are dangerous. Second of all, if you look at what the doctors write regarding the use of opioids and so painkillers in their role in the pain management, you see that they don't work. Not only they don't work, so all the trials that the industry have used to justify their prescription have been of a very short duration. So we are talking about like companies that were comparing the efficacy of morphine versus paracetamol for osteoarthritis for 3 months, while people with osteoarthritis have been suffering for years. And you see that there is no much evidence. And in those patients where the painkillers and the morphine do work, there is what we call a high dropout rate. So patients are not compliant, they stop using those medications because despite they are working, or at least are partially working, they have side effects and they cannot tolerate the side effects. Now, NICE, which is a UK organization that advises both doctors and patients, just recently, this is August 2020, has published quite a strong draft where it strongly states not to offer any painkillers, starting with opioids, for patients suffering from chronic primary pain, mainly not because of the risk, but because of the lack of evidence that they do provide pain relief in the long run. So then we are back to the same slide, right? So if we do not, if medications are not the way forward, so what can we offer for people with chronic pain? So the first thing is, let's start with the pain coming from the periphery, right? Of course, as I said before, if there is a mechanical problem, your first point of call is definitely a mechanical solution. So an orthopedic surgeon usually is the first, or a physiotherapist first, and then an orthopedic surgeon is the first professional that assess your symptoms, and usually 90% of the case might actually solve the problem. But when that is not the case, what is that can be offered by a pain specialist? Well, for a long time, we have used a technique where once we identify an area that causes pain, we can burn the nerves, the tiny nerves that innervates that area. So we don't fix the problem. So if you have a mechanical problem, the mechanical problem stays there. But what we can try to do, we can try to reduce the amount of information that comes from this mechanical area and reach your brain. How can we do that? So that is, first of all, is a very common technique. You might have heard about it. In the medical jargon, we call it radiofrequency denervation, because we use a radiofrequency energy, a radiofrequency probe, to heat the tissue and burn the nerves. Usually it's an X-ray guided procedure, so we don't do it randomly, but we have some specific X-ray target that we can reach. We reach those targets with a needle, so it's a needle-based procedure. It is not a substitute to, as I said, to fix the joint problem, so to fix the mechanical problem, but it can delay further or more invasive or major surgery. And it can be used in multiple areas of the body. So the four more common ones, as you can see, is for the joint in the cervical spine, or for the joints in the lumbar spine, or in the shoulder and in the knee. Now, I will not bore you with all the data, but just to give you an idea, right? So this is a procedure that we do for patients that have osteoarthritis of the knee, where they don't wanna go for a knee replacement, or where they are not ready for the knee replacement, or where their additional medical problems doesn't let them go for the surgery in a safe way. So here you can see in the graph that after treating those nerves that innervates that joint, those numbers are the pain scores. So 10 is the worst pain ever and 0 is no pain. You see that there is a reduction in the pain scores. Now, one group, the dark line, had the burning of the nerves, and another group had an injection inside the knee with local anesthetic and steroids, which is another common treatment for joint pain. You can see that the burning is more effective, and you can see that after 6 months, when you ask the group with an injection in the knee whether they want to go for the burning, all of them, they go for the burning, and they reach the same pain score at 12 months as the other group. There are similar graphs for shoulders, for neck and back. So this is a very common chronic pain treatment that is minimally invasive, is quite safe. And if you select the right patient, then you're gonna probably have a good outcome. Another quite common treatment that pain doctors can offer, especially when there is a problem, not in the mechanical part, but in the filtering or in the amplification parts, is this neuromodulation. So this is just an article on the Times that came out like last year. That's the Guy's St. Thomas's Hospital, where we run multiple trials of spinal cord stimulator devices to try to improve the chronic pain condition in patients, especially when this abnormal filtering is happening. So how does that work, and what it is exactly? So you remember from this picture that this abnormal filtering happens within the spinal cord. So what we aim to do is to implant a pacemaker. You probably have heard about pacemaker, like the cardiac pacemaker. We can implant a very similar one inside the spine, on top of the spinal cord, where this abnormal filtering happens, to try to, if you wish, to try to mask the pain signals before they reach the brain. How do we do it? It is quite easy. So we don't do spine surgery. We don't open the spine. We just use a needle that goes in between the bones in the spine to insert a tiny catheter with some electrical contact. You see that we do it on the X-ray control, so it's extremely safe. We know exactly where to leave those leads. We can do it in any area of the spine. We can do it in the thoracic spine for back pain. We can do it in the neck for neck pain. It's a very easy to perform, is significantly safe. It is a reversible procedure, which means that we can remove this device if for some reason they don't work, or if there is a complication. We do have the possibility to try the device and see whether it provides enough pain relief to justify the whole surgery before actually going for the whole surgery. And then the technologies, it is quite, because it's a technology-based treatment, the technology nowadays is advanced very fast, and every couple of years we have better device. They have either better waveform or better remote controls. So every year we get some form of advancement. How does it look like? So this is a patient, for example, that I've implanted recently with neck pain. You see that there is a small incision in between the shoulder blades where the electrodes have been inserted. And then you see that there is another small incision on top of the left buttock where the battery itself is inserted, the battery that provides energy to those leads. Now, if you want to, people ask how big are those batteries? Those batteries are small, and they are getting smaller and smaller every year. You can see that these are two, I would say, thick fingers, and you see how small is the battery that usually is inserted. Now, does it work? Does it really work? So I'll give you a few, let's say, a few informations, and you can decide yourself. So this is NICE, again, the same organization I was mentioning before, that has published two big papers to assess whether spinal cord stimulation was a reliable and effective technique to control chronic pain. One in October 2008, and one in January 2019. One regarding the spinal cord stimulation in general, and the other one regarding a high-frequency spinal cord stimulator, which is a type of stimulator. And you see that among all the treatments that NICE recommend for chronic pain, that is as assessed and recommend for chronic pain, two of those are spinal cord stimulations. Other three are surgical treatment, like discectomy, for example, and the other ones are brain treatment. So it is no injection, no burning has been really endorsed by NICE, but spinal cord stimulation has been. Now, to give you some numbers, right? I'll present you some of the studies that has been published. I'll try to make it easy, and very happy then to answer questions. So this is a study in US where the investigators were looking at people with back and leg pain. and see whether a stimulator was, first of all, was helping, and whether one stimulator was better than the other. So you see the gray line is the stimulator that was the gold standard at the time of the study. And the yellow line is the new stimulator that we're testing. So you can see that both of them were effective in reducing pain scores. So on the left, you can see the pain score. As I said, 10 is the worst pain ever, 0 is no pain. All the patients were starting around 8 in terms of pain scores, and mostly half of them were reducing the pain score by half. You see, from 8 to 4. But in the arm where this new device was tested, you see that the reduction in pain is even more profound. On the right side of the screen, you see you can see the data presented in a different way. This is what we call responder rate. So we define a patient as a responder if his or her pain decreased by at least half of the initial value. And you see that how many of those patients were responding to the treatment. And look at 12 months, 50% of the patients implanted with an old stimulator were improved by half. And up to 78% of patients implanted with a new stimulator were responding. So this shows that the spinal cord stimulation worked in that specific category of patients, and that the yellow one was more effective than the gray one. If you change type of pain, you see very similar results. So this is diabetic neuropathy. Diabetic neuropathy is a condition that affects people with diabetes, which is a very common condition, especially in the extremities, so feet and hands, where the nerve endings there start to die and people start to feel pain caused by these nerve endings dying. So you see on the right how many studies have been tracked in this review, for example, and you see on the left that the pain scores is reduced by using these kind of devices. And you see on the bottom of the figure that that is maintained for 12, 24, 36, up to 60 months. So it's not only working, but is also working in the long term. This is another example of pain of the use of a stimulator for neck and arm pain, for example. It is important because this is an area where spine surgeons are not extremely keen to operate, because the spinal cord there is bigger and is more sensitive to potential risk, and where a lot of mechanical pain can be excluded easily with imaging. And you see when you select the right patient, again, you see the numbers yourself. On the left, the pain scores drop from 7 to up to 1, which means that, my neck pain has got a score greater than 1 right now. So it is a significant improvement. If you look on the right, the amount of responders, again, the amount of patients that their pain reduced by 50% is way over 70%. So you see that the results are quite good. Now, some people might say, well, look, these are old studies coming from America, old study. They are in some way carefully designed by industry to promote their product. What is the real world data? So we've just published a review of 1,177 patients that we have implanted within the NHS here in UK, in London, Guy's and St Thomas's. It is difficult to compare one condition to another, but the common theme is that if the stimulator doesn't work, sooner or later, the patient wanted to have it removed because it's an external body, because it might cause some discomfort where the battery is positioned, because in some cases you want to have an MRI and these devices might not help you having an MRI. But if the device works, then definitely you will not get it removed. So we examined how many devices we have removed in the last 11 years. And these are the numbers. So among all the patients that we have implanted, every year we do explant 2-3% of the patients. So let's say it's 7 years down the line, 10 to 12% of the patients are explanted. That means that the rest, the majority, the 90% of the patients stay implanted because they consider their device as effective. Now, the question then is it dangerous? As I said, is a quite safe technique, is easy to do. There is only one danger. The problem with any implantable device is that you might get infected. And again, from the same review, you can see the explant rate that we had in the last 10 years. So again, there is 1 to 2% risk of getting this device explanted because there is an infection. And that is not an emergency, but it's a urgent procedure that needs to be done. So when people are asking me, is it dangerous? No, there is a risk of having the system infected, 3 to 5%, which is quite comparable to the risk of having your pacemaker for your heart infected. There are then a lot of other tiny details in terms of the device. I have some migration of the wires and they might not work and they require further surgery, or the battery might become not very comfortable and might needs a repositioning. But in terms of danger, this is the only real danger. So the question is, why I'm not getting one? So why I've been referred to, so we do see this very often. That's why I put this question here. Why my doctor has referred me to the pain center, and why the doctor hasn't considered me as a candidate for a stimulator? Well, there are mainly, let's say, 3 reasons, right? One is that you might not have the right diagnosis. From the same study that I like to present, because it's our patient. I've been working in gastroenterology for the last almost 11 years, so I've been very into this data. You see that there are some conditions where the stimulator is a good treatment. So you can see here the list of it, like CRPS, back pain, head pain, nerve pain, some occasional pain in the pelvis or in the bladder. But you see that the majority of the patients come from what we called failed back surgery syndrome, which is a horrible term to say that you had spine surgery and for some reason your pain persists. So if your spine, for example, look like the one on the left, right, and you still have pain, despite the wonderful job that your spine surgeon has done, because in this case has managed to remove 3 of your discs, put 3 discs replaced, and then fuse a couple of vertebrae, if you are still in pain, it's very likely that you will respond to a stimulator, because the surgeon has mainly excluded everything else, stopping all the mechanical signal coming from your lower back. So the first question, the first answer is, if you're not getting one, is because maybe you don't have the right pain, the right diagnosis to get a stimulator. The second answer would be because even if you have the right diagnosis, you don't have the right type of pain. Now, this busy graph, what it simply says is there are 4 different types of conditions that are quite notorious to be a good indication for stimulators. So the lower back pain on the left, the complex regional periods, a complex regional pain syndrome, then the nerve type pain, and the vascular ischemia type pain. And then you have on the bottom different specialists that have been presented with different clinical scenarios and that have been asked, do you think that this patient is a good candidate for stimulator? And you see that there is a 25% for back pain and 15% for complex regional pain syndrome and neuropathic pain. There is this percentage of patients that, despite having the right diagnosis, they don't have the right type of pain, and therefore they will not respond to the stimulator, and therefore they won't be offered the stimulator. And then there is this is a bit more controversial, but most of the times there is a psychological profile of patients that won't respond to the stimulator regardless of their diagnosis or their type of pain. And that is because there is a significant influence of psychological problems in the way we perceive pain, and therefore in the way we respond to pain treatment. So that's why it's important to have a psychologist that help understanding all these very weird things that I've written here, and try to help correcting those prior to get assessed in terms of diagnosis and type of pain. So if you are not getting a stimulator, if you're not being offered a stimulator despite you are suffering with chronic pain, it's because either you don't have the right diagnosis, the right type of pain, or psychologically you're not ready for a stimulator yet. So I hope that in this kind of 30-35 minutes, I've given you a bit of an overview of my life, right? My interpretation of my specialty, why I think how pain works, why there are different mechanisms, why there are different treatments that can be offered according to the mechanism, and why spinal cord stimulation, if selected as a treatment for the right patient with the right abnormal mechanism, can be a good option. Now, I left on purpose like 5-10 minutes for questions, because I'm pretty sure that being a lot of patients there, they will have a few questions. I'm very happy to answer if I can.
Thank you. That's fantastic, Stefano. Yeah, there's a couple of questions in the talk, so I'll start by asking about, someone's asking about orthobiologics actually, regarding the use of PRP. Do you have any use or sort of experience with this in spine osteoarthritis?
So there is growing evidence that biological are a new way to treat mechanical pain. So if you remember the diagram that I show you, if you have a joint problem that could be in the spine, the same way it has been in the other joints, biological might play a significant role. You know better than me that there is a very strong evidence now for knee osteoarthritis. And slowly they are translating this evidence in the spine. So we do have a bit of evidence and a bit of experience with that, but it's not strong enough to put it on a presentation, especially if I wanted to focus more on the spinal cord stimulation side of things. But yes, there is that option is possible.
Stefano, and obviously this is really clever technique, and you know, it's not clear, it's not done all over the place. There are only specialist centers like yourself who do this. Do you find that people are sending you patients from around the UK? Because we know there's an opioid problem in the States. We know there's a rising opioid problem in the UK. Are people becoming more aware of it, and you're seeing more and more people coming through for this sort of treatment?
So yes, I would say that GPs are becoming more aware about opioids, and they are not keen in prescribing it. So they are referring patients with high dose of opioids to pain clinics. Pain clinics are quite good in understanding these three different types of mechanism of pain, and they know that what could be a potential candidate for stimulators. And then we do get significant referral from mostly all over the country. Despite now there are good centers for STEAM also in the north and in the south, but we do have significant referral. And generally now in our center we have a kind of a 30-40% of the patients sent for stimulator. Then at the end go on for a trial of stimulator. So we still need to do a lot of filtering ourselves.
Okay, so Sheena Camplin in the attendees has asked, her son's completed a trial, the company made the device new, all those other people on the trial found amazing results. Can he have a different company, please? I think she's trying to find out what company you might be using, or is that, I think that's the sort of reading between the lines.
I know exactly the case, and then I don't think this is the best setting to specifically reply.
Okay.
But we will contact their son, and yes, he is going to get the trial with a different device.
Okay. There's been a couple of people asking about stem cells for the treatment of osteoarthritis in the spine, I guess specifically. Now we don't use stem cells in this country with licensing within the UK. It doesn't allow for that. But there are options to use microfragmented fat, similar to what we discussed about PRP. Have you had any experience with that, Stefano?
So I personally don't have experience with, for example, Lipogem for spinal pain. The study are coming out as well, especially for discogenic pain. So if the pain comes from the disc, which is a good environment to keep those cells in without letting them escape. But at the moment, it is quite controversial because most of the studies have been run outside the UK. So it is a debatable treatment. However, as I said before, there is a significant literature for knee pain. Now, knee is a joint that gets osteoarthritis in the same way other joints of the body. So it is reasonable to think that if it works very well for knee pain, there are no reason why it shouldn't work well for other forms of osteoarthritis. The problem with spine, which is a bit more complicated to diagnose compared to the knee, because there are many joints, there are discs, there are nerves, there are ligaments. It is more complicated to diagnose and understand whether, yes, you might have radiological osteoarthritis, but your pain might not come from there. So that's why it is a bit more complicated also to run studies.
Brilliant. And we've got Helen asking, is it effective on MS pain or facet joint arthropathy? Helen's taking daily dose of tramadol. I was due to go for corticosteroids next week. Is that sensible? So that's a good wide question, I guess.
Okay.
You know,
so
number one, yeah.
So number one, so if you have MS, which I suppose is multiple sclerosis, so it really depends where is the mechanism of the pain. Multiple sclerosis itself causes nerve pain, but it causes most of the times where if you don't have lesions on the spinal cord and you have it just in the brain, it causes more a central type of pain. Now, it's more likely that you have MS and you get facet joint arthropathies. Well, then you have simply a mechanical pain in the back, where injections could help understanding, if they target the joints with local anesthetic and steroid, will help understanding whether the pain comes from the joint. And in that case, rather than the stimulator, one of these burning, one of these radiofrequency denervation could actually help.
So in essence, Helen, it sounds like diagnosis is key and getting the right investigation, right person to see you and getting to the bottom of where this pain might be arising from is going to be key in determining how well you're likely to do from your injection. So I really hope that's answered your question. Final question from me, Stefano. With the spinal cord stimulators, if people have back-related pain, discogenic pain, can it predict the outcome of surgery in the future? Do the two have any correlation?
So this is a great question. We have learned in the last 10 years that the failed back surgery are the best candidate because the surgeon have already fixed the mechanical problem. If the pain is persistent, then probably there is another mechanism. Now we can translate it the other way around. So if you do not respond to a trial of spinal cord stimulator, that means that there is something mechanically there that is still not working. So we see it, for example, with CRPS of the knee, where we think that there is a significant nerve type pain, but if they don't respond, they do well if they undergo a knee replacement. And we see it, for example, especially in the neck, where the spine surgeons tend to operate a bit less, where if you failed as a trial of spinal cord stimulator, then there is much easier to say that the spine fusion might help. And I have a couple of private patients where it happened exactly this. They didn't want to go for cervical surgery. We did a trial. They did have some kind of nerve pain. They didn't respond very well. We did a SPECT CT scan. They had a hot disc. They went for a fusion and they are pain-free. So again, the issue with these treatments is more the diagnosis itself. Brilliant.
So I think the message is there is obviously getting the right diagnosis. You can work hand in hand with, surgery can be something that may be needed in the future, but this is sort of more holistic approach to pain management. Stefano, thank you so much for a great presentation. There's been comments in the question and answer for saying what an honest and nice presentation you gave us this evening. To all the participants, if you wish to get in touch with Stefano, do not hesitate to contact us via the Orthopedic Specialist website. We'd be happy to look after you. Thanks again for coming along. We'll post a questionnaire and send you some CPD points, and keep in touch with us on LinkedIn and Twitter, and we'll let you know about the future events. So thank you very much.
Thank you very much for hosting me, Raghbir. Huh?
Pleasure. See you.
Cheers. Bye-bye.